Hello and welcome. I'm Dr. Christina Nider, Dean for the College of Social and Behavioral Sciences at the University of Phoenix. Thank you for joining us today. We are so glad that you are here for today's essential conversations in diversity, equity, and inclusion. As you know, our world has been turned upside down by a pandemic that just hit the unfortunate milestone of 1 million deaths worldwide. The public health crisis of epic proportion has not only threatened our health and safety, but laid bare the persistent disparities that drive inequities in education, healthcare, and law enforcement. These realities have led to an important reinvigoration of essential conversations about systemic racism and vigorous debates on how to eliminate once and for all deep-seated behaviors and practices that allow these inequities to persist. To be a catalyst for essential conversations necessary to effect real and sustainable change, the University of Phoenix and the National Diversity Council have partnered to bring you a series of conversations about systemic inequities, specifically as they manifest in the societal sectors of healthcare, education, and law enforcement. Before we begin, I have a few housekeeping items to share with you. First, I would like to recognize all of our partners in this webinar series. A big thanks to National Diversity Council, our co-host for this series, and many thanks to our following partners: American Society for Industrial Security, Las Vegas Metro Police Department, Police Athletic League, Henderson Police Department, San Diego Organization of Healthcare Leaders, Cherokee Nation, and Diverse Issues in Higher Education magazine. I'd also like to set a few ground rules. We're sharing these ground rules in the spirit of creating a safe and open and productive environment to have essential conversations. Please note that participants can post questions in the chat and our moderator will do her best to get to as many questions as possible. But please keep in mind, this is a safe environment to have productive conversations that we need to have as a group and as a society. Also, please remember the Zoom link that you used today to log into our session is good for all of our sessions. So keep that handy, and we encourage you to attend as many sessions as possible. Today, we're going to be discussing disparities in the delivery, quality, patient-centered care. And I'm going to turn it over to our moderator, Dr. Kelly Price Noble. She's chair for the University of Phoenix, and she will take it from here. Thank you very much for joining us. Go ahead, Kelly.
Thank you, Dr. Nider. This is an exceptionally wonderful day for me. We have gathered 4 incredible participants. I'd like to thank you on behalf of the College of Health Professions and on behalf of the organizations for whom you work. What I'd like to do is just read a little bit of something of why I wanted to have an essential conversation with you. People of color and low-income individuals historically have faced greater barriers to accessing health care, including a higher uninsured rate compared to whites and those at higher incomes. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. As panelists in these events, I hope that we'll be able to demonstrate an understanding of the cultural needs and disparities experienced by diverse populations. Please include in your remarks best practices, taking cultural diversity into account using effective cultural communication strategies. In one of my jobs, I hope to be able to lead our audience through an understanding of cultural competencies and how to discuss open conversations and how these can affect perceptions and perspectives of reality. So I'm going to move to my panelists, Joe Avellino, DeMarcio Davis, Tomas Leon, and Deborah Freed, all of whom I am just simply honored to be in the presence. So I'm going to ask you each to please take a few moments to introduce yourselves to our audience, and after Ms. Freed goes, then I will ask you a series of questions for which you were given a bit ago. Thank you. Joe, if you would please introduce yourself first.
Good morning. How's everyone doing this morning? My name is Joe Avellino. I'm the Chief Executive Officer of College Medical Center. College Medical Center is located in Long Beach, California. We are licensed for 221 beds. We are an acute care hospital. I have approximately about 6 buildings comprised in College Medical Center. And also we have over 1,200 employees, along with 200 physicians, our medical staff, and with approximately about 1,500 ER visits a month, and also close to 500 admissions in behavioral health, and acute care side, almost close to 300 admissions a month. My background is a nurse. I've also been in the military for 27 years in the Army National Guard. And thank you for the opportunity to be part of this distinguished panel.
Absolutely. Thank you. Mr. Davis.
Hi, my name is DeMarco Davis. I am the Executive Staff Assistant to the Associate Director, as well as I am also the Chief of Voluntary Services for the Northern Indiana VA Healthcare System. So our system is comprised, it's a dual campus facility to where we also have multiple primary care centers, or what we call CBOCs, around the area of Indiana and some parts of Northern Ohio as well. As far as my background, it was predominantly in business. I've owned a few mortgage companies or mortgage brokerages, and later decided to go ahead and move into healthcare administration after receiving my schooling over at Xavier University. I also was in prior military. I was in service for 8 years as a counterintelligence agent. And but as far as our facility right now, one of our focuses is me being the Chief of Voluntary Services, is making sure that we go ahead and provide our veterans and our patients with additional care and resources that federally may not necessarily be mandated for them. But that's DeMarco Davis for right now.
Thank you. And Mr. Leon.
Great, thank you. Thank you for having me. It's an honor to be here. I just want to applaud the University of Phoenix for hosting these essential conversations. I'm a proud alumni, part of the alumni family there with the University of Phoenix, earned my MBA degree there. And I'm the Senior Vice President for Marketing and Strategy at a private equity-backed company called Equality Health. So I'm the lead storyteller and go-to-market strategist there. And just an honor to be here with my esteemed colleagues as well. Just by way of background, I'm a native from Arizona, and been in the healthcare sector going on about 12 years now. I've worked as a president and CEO for a number of amazing organizations over the last 2 decades in the business sector, as well as healthcare and philanthropy. My role prior to Equality Health that's relevant to this conversation is my role as president and CEO for the Institute for Diversity and Health Equity at the American Hospital Association, where I helped create and launch a equity of care campaign across the country with hospital and health systems. And so interesting how things have come to this point right now where that is highly relevant. And I'm looking forward to having this open conversation and learning from my colleagues and other participants, and really just trying to develop and hone strategies that I can learn from and share some of the experience that I have with others in hopes of accelerating progress around diversity, inclusion, and equity, particularly in healthcare. So thank you for having me.
Absolutely, thank you. And last but not least, and I just have to say, Deborah, I am just so glad to see you. Deborah and I have gone way back, I don't know, 2004-ish. Yeah. She and I both worked for the Paralyzed Veterans of America and used to meet each year in Washington, D.C. as we would testify in front of the Joint Hearing Committee on Veterans Benefits. And it's an honor, lady, to see you back. So please, please introduce yourself and tell us who you are, and let's go on. Thank you. You're on mute, my dear.
Was covering it. There we go. Thank you. My name is Deborah Freed. I was born in Connecticut, raised in Connecticut, moved to Massachusetts in 1994. I am a veteran. I suffered 2 active duty injuries to my back and had 2 surgeries while I was on active duty. Had a third one through the VA system in Connecticut. I went in the military 81 to 85, and 6 months after I got out, I had a third back surgery 6-8 months after I got out. I got involved in Paralyzed Veterans of America, the New England chapter. There's a much longer story, but I won't bore anybody with it, because I wanted to go to the National Veterans Wheelchair Games. And I'd never done anything with a nonprofit before. So I started volunteering, and like Kelly said, that's how we met at the 2004 Advocacy and Legislative Seminar that PVA hosts every year, including this past year. They just made it under the wire, and one of the things that I've been very proud of is that for a veteran service organization, we don't just deal with veterans, we deal with the disabled community as a whole. And so for 15 years, up until July 2019, I left the chapter at the end of July 2019. I had planned on looking for a different type of work for a while. Unfortunately, I suffered a third back injury. Let's just say I had an argument with a horse and it won, and I didn't. So I am not currently working, but I believe that I can add a little insight as both a civilian born with a cleft lip, cleft palate, and being a ward of the state of Connecticut, as well as being a veteran in the VA system.
Just trying to find my unmute, but I think I'm going to need a teenager during this thing. So, all right. Thank you, everyone. And let's get on with the questions. I look forward to hearing everything that you all have to say, and with the hopes that we can really do some justice in educating our audience. And so let's start out. Why do health and healthcare disparities matter? What's the big deal? Anybody jump in, or I can be like a teacher and I can call on people, so we can do that too.
This is Tomas. I'll go ahead and kick it off. You know, our vision at Equality Health is equal health for all. And if we're going to create a society of healthy communities where every individual can achieve their optimal health in life, then this has to matter to us. We have to remove barriers to good health for people. So disparities in health and healthcare is a top priority. We have to remove those barriers that exist, not just systemic racism, but institutional racism. Those are two distinct and separate things. And so, you know, systemic racism involves all of us. Institutional racism has to do with our own organizations or a hospital or a health system. Those things have to be addressed in terms of bias and racism and discrimination, et cetera. And so those are, you know, that's why it matters. If we truly believe in good health for all people and creating equal access to high quality care, then we have to set that as a top priority collectively across healthcare in every institution and across the healthcare sector. So that's why I think it matters. I mean, I'm fortunate and blessed to live where I'm at right now, but I grew up from humble beginnings in the barrio in Tucson, Arizona. So if you look at life expectancy in the zip code where I grew up, where I'm living at now, two distinct and far, different outcomes. And so I don't have to look too far than my own family and some of my colleagues and my friends to see those that are being impacted in a negative way, but because of the disparities in health and healthcare.
Great. Thank you.
I would like to say cost. So as far as why do they matter? One, they cost a number of individuals and groups because of because there is inequality, and also to understand that it is not only race, although that's definitely a discussion that has to be had and talked about, but it costs the people's livelihood, of course, their health status, their abilities to do certain things. It costs the system financially. So give an example that when you have a population or a segment of people in an area that don't necessarily have access to their primary care because of, I don't know, because of transportation or because of a number of other reasons, where do they typically end up? They typically end up in your emergency room. So this brings up a much higher cost for the system. Also, the care that's delivered in the emergency room, the understanding has to be that the emergency room provider is initially there to go ahead and stabilize the patient, but not necessarily address all of their chronic illnesses. So then now care fiscally it's more expensive. And also the care that's delivered is I'm not going to say it's not helpful, but at the same time, if in the event they're able to go ahead and go to their primary care visits often enough, then a lot can be minimalized. They enjoy a much better life and much better health. So I will say one of the biggest concerns is the cost.
Great. Thank you very much. Deborah, Joe?
Sure. I think for us in the Long Beach community, diversity matters, especially in the population that we serve here. It's a melting pot of Vietnamese, Filipinos, Blacks, Caucasians, Latinos, Cambodians, etc. In our back to DeMarco's comment in terms of income, and we serve an indigent community here in Long Beach and gang related. I mean, sometimes with the Cambodians versus the Hispanics, and we have to be extremely sensitive to that. But at the same time, we have to protect our employees. We have windows that are bulletproof, for instance. We have metal detectors because we've had threats before of gang related that they know that's been hospitalized on ER, and we have to be very sensitive to that as well. And along with that, I saw one of the questions on the Q&A regarding insurance. I mean, a lot of the majority of our patients here are uninsured or on Medi-Cal. And obviously, we're not allowed to ask those questions before initiating the care, but some of our physicians are extremely selective, obviously, but from the ER to our primary care docs to specialties, and that's a challenge for me sometimes. And having my chief medical officer engage, involve, and say that, unfortunately, some cases you're going to get the low reimbursement. I mean, I get it um, in my internal call medicine panel. Well, am I going to get a Medicare patient? I'm going to get a commercial patient, as opposed to, versus an indigent versus a self-pay, no pay. And it's an extreme challenging with the community, and then the expectations of our doctors and physicians. But diversity does matter. It also matters in terms of the employees that you employ. That I know I'm proud to say that I have a very diverse employee staff here at College Medical Center. As I indicated, we have 1,200 plus employees. I mean, we opened up on October 9, 2013. We only started with 250 employees. And our specialty here with behavioral health, and behavioral health is not going to go away. Whether you're dealing with behavioral health, it's pure behavioral health versus a dual diagnosis with medical and acute care, it's going to continue. And that's a very diverse community. I mean, we serve all the way up to the Silmar community, where we work with UCLA Olive View, as far as Chino Hills area on the east side. So again, very diverse here in College Medical Center when we speak about diversity here. Thank you.
Great. Thank you. Deborah, I know that your bent is going to be a little bit different, but do you suppose that you could answer it with regard to the veterans population, particularly the catastrophically injured veteran population?
Here in Massachusetts, I can pretty much only go by my surroundings. Massachusetts has the West Roxbury VA, which is the acute care center for spinal cord injury and dysfunction. And basically, we have the civilian side of that is called Spalding Rehab. So if an individual who gets injured after their active duty service, they don't always know to go to the VA. A case in point, I'll use it real quick. A gentleman who is a professor emeritus at MIT in linguistics, did military service in the early 60s and never thought that his military service would be worth anything. About 4 years ago, he actually had severe bone spurs and was stretching on his stairwell and ended up an upside down turtle. Couldn't move a thing. And so they rushed him to the hospital. And because of his age, he was, I believe, 74 at the time, the doctors pretty much told the wife that he's not going to make it. So you can start planning his funeral. He did make it. And so 30 days later, and of course, insurance is a big issue. 30 days later, he goes to Spalding Rehab for 30 days and has some minor complications there. And so he couldn't get the real rehab that he needed. His choices were he could go to a nursing home and hopefully get the rehab that he needed, or he could go home. And they were not prepared for that. And he was not ready to be in a wheelchair permanently. And so the discussion came out that he was a veteran. And they're like, really? And he's like, well, yeah, but I don't think it's worth anything. And so many veterans do not realize what it is really worth. So long story short, he goes to West Roxbury SCI. 4.5 months later, not only is he alive, sorry about that. You'll have to forgive my cats. I'm in a room with my cats because I'm having renovations done at my house. So I have 4. So I apologize in advance. I meant to apologize in advance. Anyway, long story short, he spent 4.5 months at the VA, and he walks with a walker in small places. He does use a power wheelchair in bigger spaces. And one of his besides his wife, another love of his life is playing the trombone. And he can still play the trombone. And I don't know if you can see it, but that's the gentleman. Name is Samuel J. Kaiser. And no disrespect intended, but he was one of my poster boys when I was in government relations and the executive director, because the VA system meant so much more to him because they never let him give up, never. Whereas the civilian side was like, well, it's his age. He's, you know, upper middle class, didn't matter to the doctors. It was because of his age. And please forgive me, I have to drink something. It was because of his age, they were willing to give up on him. And because of insurance, he could pay $3,000 a day to stay at Spalding Rehab or go to a nursing home. And God only knows, honestly, what would have happened if that did happen. But he's alive and well. He still performs in a jazz club that he's been a member of for decades. And it really is, you know, when a veteran, when they find out that someone is a veteran, especially after their military service, they do their best to ship them off to the VA. That's where they need to go. The professor had said, and it's in his book, that the difference is in what it would cost him at Spalding versus what it would cost him at the VA were hugely significant. VA, he didn't have to pay for anything because he's considered a catastrophically injured, which in our terms, VA has levels 1 through 8. Catastrophically injured are classified as class 4. Therefore, they get most of their medical, most of their durable medical equipment through the VA. They're not charged for that. Kelly, you might remember this. A number of years ago, PBA fought for veterans for their prescriptions. Non-service connected veterans paid between $5 and $15 per prescription. And the one thing I remember in Connecticut, when we went to DC, one of the Connecticut representatives was like, well, it's $15 for 3 months. No, they wanted to change the rules. It was $15 per prescription. So if you got a 90-day prescription, it was $45. At the time, I was taking 10 prescriptions. They wanted it across the board for all veterans, not just for service-connected or non-service connected. And so I had to clarify that with them. Said, that's $450 every 90 days. That's over $1,200, that's over $1,600 for a year. And I believe that was one of my first trips. Oh, please. Oh my God. That was one of my first trips to DC in dealing with that. And since then, PBA, we have all worked hard and we got that dropped. So veterans, catastrophically injured veterans, no longer have to pay for their prescriptions.
Yeah, I think that was like 2010, I think it was. Yeah.
Yeah, so I've been around for a little while then. But, you know, growing up in a foster care system, I was awarded the state. So which meant that when I was growing up, because like I stated, I was born with a cleft lip, cleft palate, we would have a 9 o'clock appointment in the morning and we would wait and wait and wait. And I do mean that literally until almost the end of the day, between 3 and 4 o'clock, they would finally see me. And I was one of the lucky ones in the foster care system to be in a middle-class family. But that didn't matter. It didn't matter to the doctors, to the system, that because I was a ward of the state, the payments to doctors were much lower. So they wanted to see people who could pay first. They had the priority, even though we had a 9 o'clock appointment. You know, and it's hard for children to understand, what did I do? Why were we late? Did I make us late? Did we get the wrong date? You know, and for a long time, that really bothered me because I didn't know what I did. I can't help that I was born with a disability. But I can rattle on for hours, so you have to yell at me, Kelly. You don't, you know you do. So
No worries. I think, and thank you. And I think you brought up a couple of good points. And let me just say this for the civilians who are listening, that the difference between service connected and non-service connected is the difference between workers' comp and not having workers' comp. And so if you're service connected, it means that you were injured or suffered a disability within the line of duty, LOD. If you separated and you were injured and they found that you had a disability of some sort, let's say of paralysis or something that happened to your spinal cord, that's what we would call a non-service connected injury, unless it was presumptive within 5 years of your separation. So the service connected, meaning that you get the workers' comp, if you will, civilians, non-service connected. And for paralyzed veterans or anyone with a spinal cord dysfunction, the first year it's $1 million injury. So if you are underprivileged, you don't have insurance, you live in a bad zip code or something, many people end up losing their homes, they end up losing everything. And so unfortunately, that's why you might see some of our veterans on the street. Okay, I've got lots of questions that are coming up in our chat, but I want to go on to talk about a little bit more. And what do you think are key initiatives to address some of the disparities that occur around your work?
Kelly, I'm going to touch on 4 initiatives real briefly, and then if we have time, we can unpack them, but just real succinctly, these are initiatives that we focused on in the National Equity of Care campaign I mentioned earlier when I was with the American Hospital Association, and those that we're focused on right now at Equality Health. And the first one is increasing and improving the collection, stratification, and use of social demographic data across quality measures, right? So you can't serve me if you don't know me. If we don't have a good pulse on what the gaps are and where the need is and where the disparity is, it's hard for us to develop specific clinical or community interventions to address those. So these are things that any healthcare company or hospital or health system can utilize to identify those gaps and measure progress moving forward. That's the first initiative. The second initiative is improving cultural competency training. So if in order for us to deliver care through the lens of culture and other factors of diversity, then we have to equip and train our healthcare providers to deliver culturally competent, sensitive healthcare services. So it has to be an intentional initiative and strategy that's part of that work. The third strategy is improving diversity in the C-suite, in the executive level, and on the board, right? That's where strategies are developed. That's where ideas are generated. That's where resources are allocated. So if this is not a strategic level initiative and we're not improving the C-suite and the board that reflects the communities that we serve, it's going to be very difficult for us to close that disparity gap towards health equity. So that's the third. The fourth initiative was improving and increasing community partnerships. So we are now realizing, and many of you out there may have been realized this already before, but the upstream work, the social determinants of health, those factors that impact your health and my health and the health of communities that has been exacerbated now by this pandemic are a priority. we cannot do this alone. You have to improve and increase community partnerships to strategically address those SDOH issues that are impacting the health of people and communities. And so, so I just wanted to lay those out. We can go into depth on each one of those, but I want to kick it over to my colleagues to add their thoughts or add their initiatives as well. So, thank you.
Thank you very, very much.
If I can chime on to Tomas' comments, thank you for that. But also, I mean, point well taken regarding the board of directors and the C-suites, but I would even go beyond that, as in your leadership team. You know, for me, I have close to 36 directors and managers and supervisors within my so-called management team. And again, being having that diversity within that team sets the bar, sets the example. And if I might add on to that, as well as this cultural sensitivity with regard to disparity with our physicians and members of our medical staff is crucial as well.
Thank you. DeMarco?
So, what we will say is, you know, some of the initiatives that I know that we've taken that's just hard and fast to address. One of the known causes of inequities was to go ahead and improve our transportation coordination and relationship with our community partners, specifically as it related to transportation. And when you look at things of a whole, when we start talking about access, predominantly I see a lot of it, be it because of location. I've had the opportunity to work at the VA Medical Center in Louisville, at the Louisville VA Medical Center and System, as well as Northern Indiana Healthcare System, and also VA Black Hills, which is in South Dakota, which was also a dual campus healthcare system. And so you had populations in cities of 6,400, 60,000. And when you really just go down to the brass tacks of it, you've got a state that's South Dakota, about the same size as Ohio. However, it has about 850,000 residents there. So they're going to be spread out pretty far. And so one of the challenges, or some of the challenges, really related around location of healthy food supplies. You know, so there were numerous food deserts, and the ability to go ahead and get back and forth to your primary care providers or your hospitals or whatnot. And so you had to have a very robust but also collaborative transportation system. And so one of the things I had the opportunity to do in Louisville was to develop their first veteran transportation system there in Louisville, which also took into consideration the partnership with the Disabled American Veterans. We actually worked very closely with our representative for PVA when I was there, but it increased access to all of these people that weren't able to go ahead and walk to or drive on their own or have adequate transportation service, regardless whether they were ambulatory or they were litter. So those are some of the initiatives, but I definitely agree with Thomas and Joe as far as to be cultural competent and culturally sensitive and have an understanding or an awareness of some of our people's needs. It takes people actually coming from different areas and walks of life to better understand so they can be more empathetic. And so, you know, as being a part of the diversity and inclusion committee for VA, ACHE, and also at the facility, one of the things that we strive for is really to press hope, especially when we start talking about just like University of Phoenix, is also trying to go ahead and build hope in those for disciplines across the healthcare system, because we need them in all areas. to go ahead and advance and go for those different positions, to go for the different levels of leadership or whatnot. Yes, you can. It doesn't depend on what color you are, what ethnicity you are, or whatnot. We want you here because this allows, it allows for more robust conversations amongst the team, but it also allows for identification in short areas where one may just say that, okay, well, this is not really a big deal, but because of one's experience, they can quickly say that, oh, wait a minute, it is. Case in point, I was looking over just some information for Fort Wayne, and at first glance, it's a decent sized city. I seem to see a Walmart or a Kroger's on every corner. So why is it that I see in certain, when I go ahead and look at reports that were produced from, a study done by Purdue, that we have a number of areas that are considered food deserts. And as it relates to healthcare disparities, when we start talking about food deserts and people having the lack of ability to go ahead and get or secure healthy foods like, fresh vegetables, lean meats and things of this nature, then there's also probably a higher prevalence in that area of diabetes, high blood pressure, a number of things, which again, why do some of the things matter as it relates to cost? Because now you have to go ahead and treat these additional illnesses, which could have been offset had they had the opportunity to go ahead and have access to healthy foods. And so, although I'm thinking, well, 7 miles is no big deal for me to go and run to Kroger's, that's close. But when have I seen someone push an entire shopping cart of groceries down the main street? These are people who have to walk and who have to go to the gas station, the convenience stores, which are going to sell snacks like sodas, candy, potato chips, canned meats, and things like that, which is not going to be so. The outcomes for their health is not going to be as well. So transportation comes into part, but also as we talk about cultural competency, people who perhaps have come from some of these areas to be able to quickly identify that there's a need. So awareness and understanding of, some of the challenges is going to be important in every area in healthcare. So.
Yeah, I couldn't agree with you more. One of the things that I did when I worked with the PVA, speaking of cultural competence, is I would take a lot of my veterans to a middle school to visit 7th and 8th graders, and they know everything. And so I took them and took about 4 or 5 of them with me, and to explain who they were, what they did. I had 2 individuals who jumped out of what I consider a perfectly good aircraft. One was a Navy SEAL who unfortunately got tangled up in a line with another one of his guys and landed, unfortunately, and broke his neck. He's what we would call service connected. Another gentleman, after service, still liked the idea of jumping out of a perfectly good aircraft, and his terminology was, I picked a fight with the ground and I lost it. So, and he is what we would call non-service connected. At any rate, so we would bring extra wheelchairs to the school and have the kids get in them, and we would run them through obstacle courses and things of that nature. And at the very end, we gave 2 of the 8th graders an opportunity to race against one of our veterans, and who we didn't tell him he was a 2-time hand cyclist world champion. And he said, I'll even give you a head start. I'll even give you a head start and I'll go backwards. And what is interesting is a lot of people think that people in wheelchairs or who have disabilities can move their limbs. Well, they can't. And these kids were trying with all their might not to move their limbs. And eventually the individual beat the kids, going 3/4 of the way around the gym backwards. Deborah, this was Al. And and I find it very, very interesting that some people, when you have an individual with a disability, when they go to the dentist's office, just go on and hop up into that chair for me so that I can take care of you. It's the language that we need to start working on. It's people who are parking in the blue handicap spots. Please don't park there, because there is somebody who needs it more than you. That individual may not look like he or she needs it, but it's really none of your business why they need it. So I just say thank you very, very much for everyone for talking about cultural competence and sensitivity training. So Deborah, I didn't know if you wanted to jump in and answer too. You're on mute. I can do sign language, however. You're still on mute.
That's right. Okay.
There we
got it.
go.
I got it. I'm clicking on my face here, idiot. Two points I'd like to go back to Mr. Davis's about transportation. Kelly was instrumental in helping the New England chapter start a transportation program. And one of the things the state said in order to get the grant was I could not limit the transportation just to spinal cord injury, just to our members. I had to do it for all veterans. And so when I presented it to the board agreed. My first vehicle, I wanted it to be a minivan, maybe, a large one, but a minivan. And the state said, no, you have to get a bus. I'm like, okay, great. So we get a bus and we didn't use it a lot. And then I got lucky and got another grant, and we got a minivan. And over the course of 3 or 4 years, we built up our patient, our transportation program to where when we finally had to shut it down because of money, I had 800 clients, that we could take for medical appointments. One of the primary issues in that is a lot of them are single fellows. They used the VA, but they didn't have transportation to get there. And one of the niches that we had was that I have to go for colonoscopy. My partner can take me and drop me off, but there's no way she can come and pick me up and take me home. So we call the VA, call the New England chapter. Can you pick Deborah up and take her home? Okay. The deal was we would sign the patient out with the absolute understanding that once they crossed the threshold of their door, we were done, but they got a ride. And if they had any issues whatsoever, they either called back the doctor or the number that was given to them, call a family member or 911. But in a course of our time, over 2,000 veterans got appointments they never would have had. I had a gentleman who was blind in one eye and was losing the sight in the other. And he desperately needed that eye surgery. And even though he did not require a ride from me because he had to stay overnight, they allowed him to stay overnight because he's blind in one eye and now they did surgery on the other. He did not require a ride from me, but I went and visited him and made sure that I told him, I said, you make sure they call me and I will come and get you. And I asked him how he was doing. He was great. He could see out of his other eye. So transportation really is a huge, huge deal. And Kelly, like you said about going to schools, I had the privilege of doing, we called our program, What's It Like? And we did elementary schools. And my first year of doing it was actually the year before I left the chapter. And so you have elementary school children and their questions are, well, how do you do this? How do you go to the bathroom? How do you take a shower? And we explain those answers, we're not much different than you are. It takes us a little bit longer. and we would put them like Kelly, put them in a chair and do a little obstacle course, throw a basketball from a wheelchair and see who can get it in. And, you know, it's a real honor and privilege to teach children. The only difference is you got 2 working legs. I got 4 working wheels. That's it. So, you know, that was, well, I had a great time. And Kelly, I don't know if you remember Mike Gilbo. You may not, yeah. God's honest truth. He's a man or he's a boy in a man's body. He loves doing the schools. And when I first found out he was doing, I'm like, you got Mike to do the school? What, are you kidding me? I have a mouth on me. Trust me when I tell you this. Kelly knows this. I have a mouth on me. But that boy, you allow him to teach at schools, he's great. He's the best. He really is. But those are 2 issues, as you all say, about the biases and the cultural differences is there. My 2 cents.
No, I thank you. And so what I'm going to do is I'm going to go down to our 4th question because the panel actually answered my 3rd question that I was going to ask. And after this, I'd like to entertain a couple that we've received in the chat. But I want to know, what are the ways that we can eliminate racial and ethnic health disparities? And my computer just popped up, in the delivery of patient-centered quality care. What are some of the ways that we can eliminate these disparities?
Kelly, this is Tomas. I'll get us started here. It ties both the 3rd question and the last question that you just asked. And I'm going to kind of bucket it in 3 areas. One is around access, right? Access to care, affordability, and quality of care. And so these are things that we're focused on and we're driving at Equality Health. So Equality Health is a whole healthcare delivery system. We're in Arizona. We are in California, Southern California, and soon to be in Texas. And so we have aggregated independent healthcare provider network of over 4,500 providers, including behavioral health providers and community-based organizations. That's why I said this is a whole health delivery system, healthcare delivery system. So we're focused on addressing the whole person. And so that network design, that healthcare delivery design has to do with access, because we did a community level assessment to identify where the access gaps were. And that's how we're building our network, is to engage and identify more providers in those those areas that lack access to care. And then we're working with providers to do a number of things like same-day appointments, hours of service, things of that nature that further create access to care for individuals. So I think that network design or practice design, or how you're filling those gaps in those underserved, vulnerable communities is important. So that's the access piece. The quality piece is what I've been talking about in terms of culturally competent care. So we not only aggregate independent providers in a network, but we provide training to them on cultural competency, on person-centered care, family-centered care, whole person care, culturally competent care. And so we've designed a whole evidence-based curriculum to train providers, not only the physicians, but their front office, back office, and the entire practice. Because that person experiences the entire practice, not just that one-on-one interaction with the physician. And so that's the commitment that providers have to make when they join our network, is to participate in that cultural care training program. And so the other part is you can't serve me if you don't know me. And so we've been primarily focused on physical health, but now we're training and equipping physicians to assess for behavioral health and substance abuse issues. And then we're also now, through our proprietary social cultural risk assessment, SUCRA, we're assessing for social cultural factors now that are impacting their patients' health. And so that those tools, the assessment, the training, we haven't incentivized providers to do these things change their behaviors, change their workflow and how they interact and serve people. So they're able to deliver this whole person care through the lens of culture. And then the affordability piece is a very important piece. And so we're partnering with our health plan partners to focus on designing health insurance products that meet the needs of the growing diverse populations that we're serving, right? So the healthcare delivery system and how we change how we deliver person-centered care to patients has to apply to our health plan partners, because they're designing the benefits, they're designing the programs. So including, like, Mr. Davis mentioned, the transportation. So Medicare Advantage products now are starting to include food support, transportation support. So it's beautiful to see the direction that we're going in, but we have to accelerate progress here. And I underline acceleration of progress because in this environment where we're dealing with social justice issues right now, with the disparities that has been illuminated by this pandemic, this has to be a strategic and business imperative. It's the right thing to do, right? But we have lacked the commitment from leaders and boards on healthcare companies and hospital and health systems to accelerate progress and make this a strategic and business priority. So all of these things we're talking about, if we don't get that commitment from leadership, including board and executive leadership and the president, CEO, whoever's running that company, then we're just going to continue to spin our wheels and not make any progress. So again, access, quality, and affordability, but it has to be a strategic priority, a business priority, not just the right thing to do. We all know this is the right thing to do, to make this a more inclusive society and a more inclusive healthcare delivery system. And I love Deborah's stories that she's telling, because it really grounds us in the realities of how it impacts a person's life who has different abilities. And that is the inclusive definition of diversity, not just what you see, but it's all of the other lived experiences for someone who has a behavioral health issue or is physically differently enabled. And even my use of people with different abilities and sort of disabilities, right? So it's a more strength-based approach. So I think how we define diversity and inclusion is going to be important on how we accelerate progress. So I'll stop there and
No, thank you. I
to my
wish we
colleagues
had
here.
more time. So yeah, Mr. Davis, please.
So two things. As we look to go ahead and eliminate, in the first part is racial and health disparities, is to further make every attempt to reach out really to everyone, as we were speaking before, to say that people from certain areas market, give them a sense of hope that if their wish to be in healthcare or a part of the solution, if that is their wish, that we make every opportunity to go ahead and bring those people in. So I know that I might be talking maybe on the outskirts of here's a hard and fast thing that we can do to address racial and ethnic disparities in healthcare or inequalities in there. But the truth of it is, in my opinion, when we have students that come into University of Phoenix's healthcare administration program or whatnot, my hopes is that we do have some individuals from those areas or those backgrounds or with certain disabilities or whatnot that participate in it. So as time progresses, those are the people that can go ahead and have some, I'm not going to say skin in the game, that it's tangible to them. I know what it's like. Common example, when we start talking about just economics and income. I remember being a college student, single dad, 2 children, not a lot of money. And I had a doctor's appointment that day. It's 40 minutes away. My school was also 40 minutes away, and I had a quarter of a tank. So anyone who's ever paid attention to gas, I could have went to school the next morning, or I could have went to my doctor's appointment, and I was not going to receive a check until that Friday. It would take a half a tank to go ahead, or a little more than a half a tank to go to both of them. So either which way, I chose to go to school. I did not go to my doctor's appointment. I felt that I was healthy enough. So I have that understanding when it comes to income. So in hopes, and I'm glad that I have the opportunity to be in the healthcare administration realm to give back, also to have to identify when I can hear certain people say, well, this is my problem. And I can kind of see a little past that to say that, well, what about this? Oh, yeah. So now we may have a solution for that patient, and especially goes into, just like Thomas was saying, behavioral health, mental health, the social health is big. But lastly, what I'd like to say, just like Tom was saying, it has to be a strategic and business imperative. This is not something that a medical center can do on its own. It's impossible. You have to have community partners. You have to have some of your elected officials working together to go ahead and do it. As I looked with just Fort Wayne recently, you have elected officials, you have medical professionals, you have our hospital systems. All of them are coming together to address, just like I said, the food deserts, access to healthy foods, and access to healthcare. Everyone has to work together. And even, the VA, I understand that we predominantly focus on the veteran population. There are still disparities even within that population that deal with a number of these other things, or a number of these other causes. So it takes everybody to be engaged in it, and us to communicate across the board with our community.
Thank you. Joe?
Sure. I think, let me first begin. It's interesting you both, DeMarco and Thomas, commented about the behavioral health population, because in our ER, approximately every month, a minimum of 250 behavioral health patients we have in our ER. And along with that, we have approximately close to 500 admissions a month. So it's a huge opportunity in terms of disparity in the behavioral health population. And also, a lot of them are homeless, they're indigent, they can't afford to pay for the care. And so setting up something like the terminology is eligibility enrollment company that I work with, to provide better funding for those so-called Medi-Cal patients or self-pay, to get some sort of insurance for these patients. Along with that, I deal with a detox population, where we deal with alcohol, benzoid, and opiates, and dealing with the underserved community and how we manage this population. And again, it's voluntary, and obviously some of my addiction medicine physicians are selective because of their inability to pay. And obviously you have to be able to convince these doctors that, because they show up in your ER, you certainly can't turn them away, because of potential EMTALA violation, obviously, to factor in. So there's certainly education that's really crucial. Another solution that I think that's crucial is getting your human resources involved and educating your leaders as well about, as Thomas commented on, cultural sensitivity. So, and yes, governing board is important. Yes, the executive team, but when you talk about your human resources department, which impacts not just your leadership team or executive team, but your employees as well. in terms of that culture sensitivity training. And also just having that discussion and dialogue in your leadership and management meetings, and having a hard conversation about it, I think is important. I address it in my agenda as a point of discussion, and at least quarterly in our leadership meeting here at the College Medical Center. Just to illustrate a few examples.
No, thank you very much. Deborah?
There we go. One of the things that I know that the Boston VA, which used to be a full medical center, is now strictly outpatient. But one of the things that I know they did was they were getting ready for one of the big inspections, the JACO inspection, and the management of the hospital turned around and said, because they were getting all these so-called complaints, well, I can't read this sign, or, when I walk from the parking lot to here, there's so many potholes that I'm afraid I'm gonna fall, or I just got my front wheel stuck in a grate. And so one of the things the medical center did was it offered their personnel a couple of hours of comp time if they would participate in this little study. Mr. Leon, you would have been, say, a wheelchair user. Mr. Davis, you would have been portraying someone who is blind. Kelly, you would have been someone who used crutches. And you did that for 2 or 3 hours of a day. And it gave, from what I heard, it gave the able-bodied individuals and the hospital staff the opportunity to say, that's not a complaint, that is a legitimate issue that needs to be addressed. I've always had the philosophy, there but for the grace of God go I. And another little thing, like I said, I'm going through home renovations to make my house more accessible. I'm a wheelchair user versus being wheelchair bound. And so they wanted to put a ramp. I had to have access from my bedroom to the ramp to the sidewalk. And they wanted to put the ramp down, which is great. And then they put a sidewalk at 90 degrees. So I'd have to stop and make a turn. Anybody knows, anybody in a wheelchair, having to slow down to make a 90-degree turn does not make us happy. So they got to fix it. And they're like, well, what do you want us to do? We'll make it curve. And they're like, what, an S curve? Yes. And I specifically told them, I said, have any of you guys sat in a wheelchair? And they're like, no. Well then, sit in a wheelchair and see how you like having to go down a ramp and make a 90-degree turn. Okay, I have a beautiful sidewalk. The guys who did the work were excellent. So I go down my ramp. I don't have to stop to make my turn. I just go and keep going. My hand cycle, I can now ride it up and down the ramp, and I just keep going. So, but that's something that, I don't know if anybody's thought of before is have your personnel, if they've never been disabled or had suffered. I know one of our carpenters had spent time in a wheelchair, so he understood what I was complaining about. Yeah, I can whine really well, and so that would be something to look at as far as cultural and the biases. Just to give someone an idea of like, well, I'm always whining about the potholes in the parking lot, and now they understand. Yeah, there's a valid reason for that. My chair, if I'm trying to get across the street or across the parking lot, my chair dumps me I'm going to get hit if people don't see me right away. Because I'm not higher than 4 feet when I'm in my chair, which by the way, I happen to be in. But I think, that's a big thing is, you have to help people understand, but they don't if they've never been in that situation. Mr. Davis, you're a veteran. You know what it's like. You worked for the VA. I like to tell people lately these days, is the VA perfect? No, it's not. But I don't want to go to the civilian side of it because the VA was the first in spinal cord injury care. VA was first in cardiac care. VA is first in traumatic brain injury. And so the VA has a lot of firsts, and they do a lot of work. One last point I'd like to make is I had breast cancer in 2011. And so the breast cancer or the breast care doctor would ask me soon after that if I would be willing to allow residents to talk to them. And I'm like, what, you want me to teach? Oh no, I'm not good at that. And she goes, trust me, you're good at that. I can ask you. And she says, you'll be fine. And so they come in 2 or 3, sometimes young men, sometimes young women, sometimes both. And I'm like, veterans can be considered a very different breed of people. And when I look at that, it's like, I'm not any better than Kelly. I'm not any better than Mr. Avellino, not any better than Mr. Davis, even though we're both veterans. But the care that I get, I'm very blessed to be here in Massachusetts and the Boston VA healthcare. Yeah, I am very biased when it comes to that level of care because it's very good. I'm very lucky. I think one of the other points that I made out is and I do it myself, is categorizing people. Is we're all human beings. Being a female, what did I write? I wrote being female, being white, being a lesbian should not in any way, shape, or form preclude me from the same healthcare as anyone else. Same with all of you. We're all different, but why should, nobody should get better healthcare than somebody else. I'll stop there.
No, you touched on a couple of points that I think are real important. When I was at the San Diego VA, we went through Plaintree. And so I got in a wheelchair because I knew pretty much what my guys and gals were up against, but I wanted to show what other people. So if you can just picture in a wheelchair going into a restroom stall, shutting the restroom stall, and oh, by the way, the restroom stall is not accessible, how do you get out? And I'm just going to leave you to figure it out yourselves. And all you have are your wits, and maybe if you're lucky, you've got your limbs. And so people finally understood, oh, you need to be able to get out and in. So I'll just leave you with that picture. Okay, so for those of you who know me. I would like to ask a couple more questions, and then we're going to close. We've got about 10 more minutes. We're going to close with Dr. Nider. But I would like to ask about, gracious, there's so many great questions. How do you think, what are your thoughts about disparities in the conditions that are controversial, such as transgender care? Many of the disparities are exacerbated by personal options of providers and then compounded by race. For example, Black trans patients have some of the worst outcomes.
I can take that question. Going back to the behavioral health population here at College Medical Center in Long Beach, we do get a few transgender patients. As a matter of fact, we have a protocol of how we address this patient population, as simple as, and also can be complicated, that we have private rooms for these patients, and also educating our staff miss or he or she, we actually had a litigation against us where we actually had to put competencies into place and educate our staff regarding how to manage the transgender population. So it is very real, and being culturally sensitive and being able to manage the population is crucial. And educating not just the nurses, the behavioral health workers, the ancillary services that deal with that population. I haven't seen it as much on the acute care side that we serve, but definitely for sure on the behavioral health population. Um, yeah, that's all I have. Thank you.
No, thank you. Thank you.
So we receive training. Everyone has to take specific training as far as dealing with diverse, some of our diverse populations, equal opportunity in healthcare training. All of our staff members have to go ahead and take that. The VA does see a fair amount of transgendered individuals as well as we have a plethora of people not only that we treat, we do also have them on staff. Okay, so I can't say to the questioner that there are not prejudices out there or thoughts. However, I believe that the VA and the teams across the nations work as hard as they can to make sure that those patients are given exceptional care and care equal to everyone else, because in fact, we are all different. But one of the things that we make sure of too is that the employees themselves, we I believe mirror our community in this case.
Yeah, Kelly, I started this conversation with some of my earlier comments about a vision, right? A vision of equal health for all people, regardless of who they are, where they live, their economic status, etc. And that is something that if we unify and embrace that vision, we're going to do everything we can to implement policies and practices and standards to achieve that equal health for all. And, again, I love Deborah's real practical stories and giving people lived experience where they're not knowledgeable or aware of what it is to be walk in or sit or in someone's shoes. So I think it has to be very intentional in how we define diversity. And again, I'm advocating for a more inclusive definition of diversity. Race and ethnicity certainly has been a driving factor and has impacted communities of color, but so has other populations have experiencing great deals of disparity in care and health. And so, there's the Human Rights Campaign. They do an excellent job at helping assess organizations and companies and evaluate standards and practices and rates and benchmarks individuals. So if there are companies that are serious about doing that, then that's a great resource to implement. I think it starts with our vision and then pursuing how we're going to make that a reality for all people.
Thank you very much. Deborah?
One of the things that I've also volunteered for, it's actually how I met Joy. Her sister-in-law started, it was originally called Children from the Shadows organization, about gay and lesbian youth in schools and church and whatever. And so over the years, it has morphed into, it's called OurTrueColors.org. And her name is Robin Michaela, and she actually recently retired as the president and executive director of the program. Has been going all over the country to teach police and hospital and schools about, well, this person come in one day wearing jeans and a t-shirt and a short haircut, and 3 weeks later they have a little bit longer hair and they're wearing a dress. And what do you do and how do you do it? So Robin was it has been instrumental in getting courses and trainings for hospital workers, uh, uh, like I said, hospital workers, schools, police, fire, and has even been invited out of the country. I know she's gone to England. I think I'm trying to remember. I can't remember all the places that I know she's been invited to, but it's that's where it starts. It starts at home. I grew up where you didn't mention the word lesbian in our family. I wasn't allowed to play sports in school for that reason. And well, it didn't work, but what can I say? Uh, but yeah, it's definitely a community process that has to be done, because without it, it's not going to work, and people fall away, fall to the wayside, and we can't afford that. We really can't. We can't afford to lose more people. Will you stop? Sorry, Charlie Chaplin. So sorry.
I agree. No, thank you. And I want to end on this last question. We've got so many more, but I think everything starts from corporate and everything comes down. And if corporate is willing to buy in for change, if corporate is willing to change, we know that corporate has to change, but there are these little inequities and people have feelings and whatnot. So if we have leaders up at the top who are willing to help create equal access, one of the questions is how many people of color are running institutions of care, healthcare, hospitals, nursing homes, things of that nature. Do we have many? And are they there because they're qualified, or are they not there because people don't feel that they can get along? Or is that why so many people have started, buying or creating businesses for themselves? That was just one question.
Yeah, excellent question. During my time at the American Hospital Association with the Institute, we would do this disparity benchmark survey every other year. And part of the survey was assessing the diversity in the boardroom and in the executive level, and then among the chief diversity officers and middle management. And so every year that needle did not move. There was still 14% people of color at the board. These are for hospital and health systems across the country. 12% in the executive C-suite level. The only needle that was moving was middle management. There was a growing diversity among middle management leaders, but there were not breaking into the executive level, the C-suite. So there's a barrier there, and there's a lot of work to be done in terms of how do you not only recruit and hire diverse talent, but how do you prepare them and promote them to those leadership levels where they're going to make these strategic decisions and budget allocations, et cetera. So there's still a lot of work to be done there. But you can apply that same to other healthcare organizations in the healthcare sector. We're in the people business. Out of any business sector across the country, we should be leading on diversity and inclusion and equity because we're in the people business. And so that's what gets me fired up, is that we gotta, not because of the moment that we're in, right? It's a catalyst right now to change. And that's why I think these critical conversations are essential to have as a broader society, as a healthcare sector, but have these kind of critical conversations in your own company, in your own workplace, among your own teams. And so a lot more work to be done. But I do think those that are in positions of influence and power and leadership have a moment in time right now to embrace this opportunity to accelerate and champion change.
Great. Thank you very much. Dr. Niter, I think it's your time to jump on in. And I just want to say thank you very, very much to our panel. You are awesome. You are great. You are fantastic. I allowed you. I just thank you very, very much. And I will be in touch with you after the summit. Dr. Niter?
Yes, I just need to piggyback on that and say thank you so much for this rich discussion, this important conversation, these essential conversations. We just need to continue to have these to ensure that we can bring change amongst our organizations, within our communities. So a big thank you to all of our panelists for your expertise today, and a big thank you to all of our audience members who joined us. We still have another day of essential conversations tomorrow. We still have this afternoon, we have another session at noon Pacific time. We have two sessions tomorrow, a morning and afternoon in higher education will be the topic. So please continue to join us at essentialconversations.eventbrite.com if you are able to join us. And we just want to say thank you again from the bottom of our heart for joining us today. And thank you, and be safe and be well. Have a wonderful day, everyone. Thank you again.